Good afternoon, everyone. Thank you for coming back to the Boston Biomed event this year. We're thrilled to have you. I'd like to introduce our next panel. The topic of big data. We have some industry experts here who are going to share their experiences with you, and I'd like to introduce you to the panel moderator, Dr. Jennifer Joe, who is a Harvard-affiliated generalist who works with several local hospitals here. So please help me welcome our panelists.
Thank you, Lori, and thank you to everyone for joining us. I know this has been a really difficult year, so I really appreciate you coming out, joining the group, having this really important discussion, and really helping the transformation of medicine. So we're about to get started, and I'd like to invite anyone who wants to talk about big data and continuous monitoring to join us. I have some wonderful panelists up here. To reiterate, my name is Dr. Jennifer Joe. I was the founder of MedTech Boston. I'm a digital health enthusiast. I'm the JMIR ambassador. I consult for a number of companies in digital health, including Boston Scientific, and have been devoted to this space and what we're talking about. I know we're talking about data and big data and the continuum, and I do want to hear from the audience. Can you raise your hand if you're interested in big data? Everyone's interested? We all like big data. Okay, can you raise your hand if you're interested in big data in the hospital? Okay, we don't care about big data in the hospital. Oh, we do care about big data in the hospital. Do you care about data as it follows the patient into the home? Okay, perfect. We're all aligned. I'm super excited, and I want to take this opportunity to introduce our guests, have them say a little bit about themselves. They're all dear friends working on cutting edge research and leading fantastic companies. Trevor, should we start with you?
Absolutely. Am I on? Can you guys hear me? Great. My name's Trevor Perry. I'm the founder and president of GoodCell. GoodCell is actually the first personal biobank. We focus on dynamic change with data. So starting off with genetics, blood testing, so a physical bank of cells, physical bank of plasma, but also the genetic data that goes behind that. So we're a company out in Waltham, and we work with a lot of the hospitals and groups around here. So.
Thank you, Trevor. Dr. Bhatt.
Thank you. Hi, everybody. My name is Dr. Ami Bhatt. I'm an associate professor of medicine at the Harvard Medical School, and I used to direct outpatient cardiology at the Massachusetts General Hospital. Just recently, I've been promoted to the director of telecardiology because, as you all just raised your hands for, we are really moving cardiac care out of the hospital and into the daily lives of our patients.
Congratulations, Dr. Bhatt, on the director of telecardiology. Yes.
Thank you very much. You know, it's exciting for, I think, everybody here because it means that the field that we're all interested in is being recognized. So that's something good for everyone. On the side, I actually work with the American College of Cardiology, and I'm the president-elect of the American Heart Association, both organizations really interested in thinking also about AI, machine learning, but importantly, making sure that diversity is included and that we don't worsen the digital divide. So that's my area of research and passion. Thank you.
Okay, Dr. Bhatt, before you move on, we do have a textbook that we're publishing together. Could you just talk about where we are in the textbook? Sorry.
Absolutely. Springer Publishing has expressed an interest in health informatics in the digital health space. And so we have a textbook with numerous authors really across the globe who participated. And that textbook in telemedicine, digital health, and cardiology will be coming out in the next 3 weeks.
Very excited. And you lead the AHA and the digital consortium.
She just keeps going. We also have telehealth workbooks out with the ACC for actually helping practitioners use digital health in their daily care and management. And then lastly, with the American Heart Association, as well as with Newton Wellesley Hospital, local to here, we're going to be building some digital health clinics, really trying to bring this kind of care directly to the patient. Part of the challenge of that big data is it's going to be patient-sourced big data, and would love to get your questions and your thoughts on what that means for all of us.
Yeah, so we'd love to make this interactive. So go ahead and start thinking of questions, writing down questions. Thank you, Dr. Bhatt. And Dr. Bratt, I've known for a long time. So we've been in a course together, I think, that you have been leading with Adam from CMIO of Brigham. So Dr. Bratt has been a real leader at the forefront of data, how data can be used. He's a surgeon. Am I making all of this up? He's a surgeon, was one of the first surgeons who was like, we're going to really harness images. like a long time ago, because we've known each other for a long time, built a company around that, runs the Harvard informatics course, probably the longest medical informatics course there is, launches new companies, new startups out of that, along with Adam Landman, CMIO of Brigham. And then you're going to update me on what you're doing now, right?
Well, can you hear me? Oh, great. Okay. Yes, thank you. That was actually a wonderful introduction. So my name is Gabriel Brad. I'm a assistant professor of surgery at HMS and bioinformatics. I'm a surgeon and intensivist at Beth Israel Deaconess Medical Center. And I have a faculty appointment in the Department of Biomedical Informatics, where I teach a health IT innovation course now for 7 years with Adam Landman. A few other things that I'm involved with, I run the Surgical Informatics Lab, where we build informatics tools and its applications in the surgical space. I also am the co-founder of a health IT company that was one of the early companies mixing imaging and AI together to improve patient care. We exited that company last year, actually.
Okay, that's a big deal. Congratulations on the exit.
And I also am involved in consulting for and assisting with new ventures for students who come out of some of these courses and people who are thinking about how to apply informatics in the post-acute space and in the surgical space as well. So I'm really excited to have this great conversation today.
Thank you for those wonderful introductions. And I know our audience is thinking of some great questions. As a reminder, we have the president of GoodCell. So genetics, genomics, what are we doing with current data and that? Where's it going? And how can we really be on the cutting edge? We have Dr. Bott, cardiologist, forefront leading telecardiology for Mass General and larger and leading multiple societies, including the ACC and the AHA. And then Dr. Bratt, surgeon extraordinaire, combining AI, images, and also has deep understanding of what the surgical suite needs. So to start us off, I just want to talk about what is current data collection now? How is it different from where it was before? And are we able to meaningfully use that data? Because everyone knows that, right? How good is our data? Do these guys have the good data? How do they get access to it? Can they do something useful with it? Should I point or?
I'll go, and then we'll have the surgeon go after me and trump what I say. All right.
Really?
So cardiology, probably, and I'm biased, one of the best places for data gathering since the beginning of time. So we do a great job with data gathering, and part of the reason is we use a lot of devices already, and they're medically prescribed devices. And so when we're giving out medically prescribed devices, especially in the heart failure and the electrophysiology space, it means that we have really well-established mechanisms for bringing that data back in. Now, there's three things to it. One is it's absolutely useful for us because we have well-established workflows on the medical side to be able to take that data, understand what to do, and then clinically communicate with our patients. That's been well established. When I look out into a group of people thinking about biomed devices and how you can learn from that data that we have created in cardiology, that actually goes back to the companies because it goes back a little bit to who owns that data and why they own that data and whether you can access it. And that continues to be a little bit of a challenge. There's a limited version of that data set that can be available for academia. There's probably a deeper version either by you and your company or by companies that you would like to get to know to be able to do some of your analyses off of that data. Let's take an EKG, for example. Boy, if you could get your hands on the hundreds of thousands of EKGs that we're doing, how much we could learn. And so I think that's an area for us to talk about and grow. And then I think the last part for us is the non-prescribed data. So not the devices we're sending out with good systems, but what are we going to do with cardiovascular health the way, I'm just going to use a name, Apple is having patients measure what they have, or Fitbit or Garmin or whatever it might be. Where does their sleep come in? And we don't know yet how to efficiently bring that data in and then have it join with the rest of clinical care and medically prescribed data. So I think that's an area of growth and a real area of interest for clinicians to have companies answer that for us instead of making us answer it ourselves.
So, but Dr. Bott, I think that's really interesting. To recap what you said, overall, you have very established medical devices that you trust the data from. So the data is pretty clean, you think, in the cardiac space. There's large amounts of that data. And the question is, how do you use that data to do something meaningful? And you sit on the executive team at Mass General, and you're thinking, how do I bring in companies to meaningfully use the good data that we have? So I think we're going to hear from Dr. Bratt. I'm an ER physician, so our data is terrible and all over the place. But maybe in a more controlled setting, like the surgery, how good is your data? I haven't had this discussion with you.
Actually, I think that the OR has been while being a highly controlled space where there's significant amounts of data that come from the vital signs machines, from the anesthesia machines, the overall space of the OR has essentially been a black box. This is kind of a common cliche name that's been used, but it's very unlikely that with the exception of a small amount of documentation that's done by a nurse and a document that's prepared by the surgeon, it's not really all that clear what happens during a surgery. And so I think that this is actually a time where the technologies that are available to start to parse out what's actually happening in the operating room are starting to come to the fore. There are a number of robotics companies and surgical informatics companies, health IT companies that are making a foray into the operating room with the specific idea of understanding what actually happened during the case and how that actually affects the outcomes of patients. And this has a tremendous impact on a lot of device makers because there's clearly limited information as to how a device is being used or what are the impacts of certain uses of that device. And so I think this is an interesting time because there's a lot of investment that's been going into basically opening up the operating room, giving people insight into what's happening during the operation, and then helping both device makers, but also surgeons and regulatory bodies better understand how the processes of care are actually being played out during the operation. So to answer your question specifically, there wasn't data. There's now the possibility of data, and as more and more hospitals and groups integrate some of these technologies, then the opportunity for seeing how this information can actually affect development of new devices or improvement of devices is basically totally open.
So that's really incredible, Dr. Bratt and Dr. Bott. So what I'm hearing is that we are at a transformative space. We have good data in cardiac care. How can medical device companies take that data, give it to Dr. Botts of the world in a meaningful way? Dr. Bratt is saying, wow, the field is it's blue skies. We didn't really know what happened in the OR. We're getting good data, but the opportunity is just massive, is what I'm hearing. Transformative, maybe. And then Mr. Perry, CEO, President, recently CEO of GoodCell, really doing some fantastic work with collecting interesting data that's going to be transformative in terms of more pharmaceuticals. And I think we're starting to see the space of data, med device, the connected patient, biotech and pharma, all coming to this convergence. So, Mr. Perry, what are you seeing in terms of the data you're collecting and your interest in it?
Yeah, well, I really like both of those because it really speaks to the fact that there's a frontier out there. We're just starting to see this. I think that there isn't a person out there that's working in the big data space that doesn't say there's a lot of big data. There's so much that we don't know what to do with it.
Okay.
In fact, most companies are building what we call data lakes just to store the data because we have no idea where to start or where to go with it. When I see the space and when I see the fields, the two things that come to me first and foremost is both being predictive and also being reactive. So thinking about what you're doing before surgeries happen, before you have to go to the hospital, and how that data can be used there, and then ultimately how it can be used afterwards. So if we think about what medicine is evolving into. Medicine is evolving into a space where we're really starting to think a lot more about the holistic view of what we do and how we treat. And so when we think about what we can do as early on as possible and how that data can help us with outcomes through the systems, that's really where data is heading, and where we need to be focusing on as commercial organizations, as hospitals, both those that are trying to make money off of it, but also those that are working for the betterment of medicine as a whole. The other thing that I think is very important that I was hearing was it's not about a data set. It's actually how data sets work together. So if you think about quantity versus quality, quality is something that companies can do a better job of. The idea of working together to make these data sets so they're not in a black box is something that we should all be striving towards.
I just want to underscore that. Thank you so much, which is going to just segue into the next question of, we have data now. How are we sharing that data? How do we utilize that data? How do we make sure that the data is clean? So, Dr. Bhatt, cardiologist, you started us off. What do you see in terms of, I'm the new chair of the Mass Medical Society IT committee. We talk about interoperability. I know I'm going to use that word. I'm sorry. What do you see in terms of the interoperability and the meaningful sharing of data? Is it already happening in cardiology, or is that a big hurdle?
It depends on which data you're talking about.
Oh.
So the electronic health record, for all of its challenges to the average clinician, has done a great job of having us have all the data in the right place. When I talk to companies, however, who are trying to come into this space, I feel like there is this focus on interoperability with the electronic health record that is holding many companies back from the ability to really look at the data and the process and the patient's journey and the patient's information and put that together for us. I will tell you that back when, pre-COVID, if you will, it used to fall on the clinician to help you come into a system, and therefore that clinician wanted you to be interoperable. We're now no longer doing that. We are now, we have a large steering committee at Mass General Brigham. Adam Landman actually kind of helps run that. Gabriel and I are involved, as well as others. But we have system-wide understanding, in some places, not all yet, that infrastructure needs to change and infrastructure needs to bring data in. And therefore, I would say if you have a really good device, if you have a really good company that's going to take big data and analyze it, focus more on what your value proposition is and bring that to us, rather than saying, look, I'm interoperable. Now, is it nice if you're interoperable as well? Sure, I love that. But I think the first idea is we don't want to stifle kind of creativity. I can make the same argument in the other direction for you, but today I'm feeling this way.
So I think that was great. And I just want to underscore that is, I would say, a massive shift in clinicians and executive approaches towards bringing in new innovation, which there used to be a large focus of interoperability, making sure the data flew through the EHR. And there's been barriers to that. Now we're interested so much in the data doing something meaningful with it in terms of predictive analytics, connecting the patient. When I am in the ER and a patient brings me information, it's less concerning that it actually funnels into the EHR because you're doing so much more, something more meaningful, and you're giving me background on the patients. So I just want to say that this is a massive shift that Dr. Bhatt, okay.
Can I add something?
Me, or you're going to underscore something?
No, I'm gonna agree with you, and I'm gonna go ahead and take the look on your face and say it's okay for me to go here.
Okay.
I'm not saying that EHRs don't have the responsibility to allow open API and get stuff in and stop inhibiting that.
Yes.
Okay. However, in the meantime, feel free to work on what you think is valuable.
Perfect. Yes. EHRs need more accessibility, cleaner exchange of data. And I'm sure I'll dive into that this year with the IT committee. Sorry, Dr. Pratt.
Yeah, no, I wholeheartedly embrace interoperability. I think that there's no question that one of the biggest barriers to improved healthcare in the United States is the inability to share data from when you go from one ED to another ED, for example, or I just heard literally the other day of a case where a person got had a baby at one hospital and then had the second baby at another hospital, and because the two hospitals didn't share electronic medical records, then the information about what happened during the first childbirth was not available during the second childbirth. And that's a tragedy, right? Like that should never happen. And those kinds of things, those are signs of the ways in which information which should flow is breaking down and inhibiting the care of patients. But honestly, I think part of the problem is that if you really think about it, is that data has value. And so there is a difficult kind of balance that exists because data silos exist because they have value to the people who hold on to that data. And so if in order to improve interoperability, the way to do it is to essentially ensure that everyone who should have access to data has that access, and that would then reduce those problems. But I think that the fundamentally the idea of whether there should be interoperability is obviously very, very high. The value is very, very high.
Maybe I refocus the question in surgery, because that's your special. I know that you run informatics for all of the Harvard systems, and maybe we want to talk about that. But in surgery, if there are special medical devices or innovations or predictive analytics for surgical suites, it's more of a closed system. Is it more important for the data to really meaningfully come through the EHR, get that data accurate, and then spit it out to you? Or you're thinking...
Yeah, no, that's a great question. So one, although I would love to say that I run informatics for the entire Harvard system.
You have a lot of influence on it.
So I appreciate that, just to be, but what I will say, which is definitely true, is, and I think there is this thing that is happening now among many of the device companies in the surgical space. And that is that if you look at Stryker, if you look at Medtronic, if you look at a bunch of the groups that are huge device producers in this space, they are really focusing on building out a digital tool wrapper around these devices. And I think that has a lot to do with an interest to be able to not only provide additional value for how to use those devices, but also to get the kind of information that allows them to iterate more appropriately. And right now, those systems are relatively closed so that a device manufacturer is getting data about their own device. But in the future, I could easily see where, as standards become more universal, where everybody benefits from the open movement of information. And so what will end up happening is these digital tools will start to use groups of universal APIs so that anybody can pull information from a device and get better understanding as to how that relates to the care cycle. So as it relates specifically to what you're describing, I think that there is a movement in that direction. Right now, it's such a nascent idea to develop a set of digital tools that exist parallel to any device that's being used in the operating room, that it's a very early time and people are still figuring out how to do that.
That's interesting. Thank you. Mr. Perry, over to you. Sometimes data is so valuable and so cutting edge that patients don't necessarily wait to go to the doctor to have these discussions or have these investigations. And Mr. Perry, I think that's where you're sitting with GoodCell. Is that right?
Yeah, that's correct. I think being in the genetic space, everybody knows the black eye that 23andMe and some other companies, when it comes to privacy of data and who owns that data, it's a difficult line to walk. And so when you talk about value, what's the value of medical data? Well, when we started GoodCell, my co-founder and I, Dr. David Skadden from the Harvard Stem Cell Institute, one of the biggest pillars that we put into this was individuals need to own their data. The idea of democratizing data is something that we need to be thinking about as innovators, as members of the medical community. The idea of how do you collaborate? Well, the best way to collaborate is for the person whose data it is to be able to be in control of that and to say, hey, listen, I need to use this for something. It creates an environment where data becomes very rich. Data is much more at that point about how you use it instead of how much you have. And so the idea of being your own data hold, right? To have everything possible so that then you can provide that to different groups and for that data to then become utilized. And so then it's much more about the algorithms of how the data is used instead of how much of it there is.
So I think that's beautiful. And I want to underscore that we have classic academic clinicians up here. And I'm maybe questionably a classic academic physician. It's important for patients to feel empowered to seek out new information. Science is changing rapidly, dramatically. The innovation you're delivering is changing rapidly and dramatically. So at the end of the day, we want our patients to get the best care. And I love that this talks about Dr. Bott saying, we need to connect it in the home. And Dr. Bratt saying, surgery is a little bit of a closed space. And if we open this up a little bit, do some exchange, do some analysis, it's wide open skies. We could dramatically transform how surgery is delivered. And Mr. Trevor saying, there's so much happening in biotech, cell and gene, genetics, genomics. Maybe we don't wait for hospitals to catch up, and patients need and have the right for that. I'm not going to have that discussion today. And I'm going to move into what's also very important for you, which is as a medical device manufacturer, innovator, thinking of new brilliant ideas, what's the payment model? How will you get paid? And first, I was told that I should ask, have payment models in the hospital changed? So we'll talk about that. It'll be fast. Oh, okay. Dr. Bratt's going to talk about have payment models for in-hospital care changed?
I certainly think that, so if the question is, have we transitioned away from traditional fee-for-service payment models and are looking at alternative models? If you look, there's certainly a huge amount of activity in the startup space around thinking of new ways to provide services to patients. And so I think there's a lot of excitement around that. I mean, the reality is that at least for now, and this may not be something that continues, but at least for now, the general kind of, we still are doing things in the fee-for-service model, but that there's no question that over time that's going to change, as with the huge amount of pressures that exist from multiple directions, including the kind of innovation that exists around groups taking on risk, thinking about different ways of providing services. There's no question in my mind that although we still exist within one kind of payment model, that continues. There are all these pressures that are pushing in all these different directions away from that.
Maybe I apologize. Maybe I'll make this more specific. Where are we with I'm not a surgeon, with the bundled knee replacement or the bundled hip replacement? And now that we have these bundled services, there's a lot more room for innovators to say, I'm creating true efficiency. I'm creating better outcomes. Dr. Bratt can discharge this patient home and know that knee's going to work great. And because we have this bundled payment, now I have a clear pathway for my innovation. Can you elaborate on that? And if there's something past the knee and the hip and maybe a shoulder and a hand?
This is a great thing because it actually comes full circle. In order to do any of these things, you need to have data that is robust and adjusted and appropriately insightful into what's happening. So the problem, at least in surgery, is that the reason why people have chosen the knee replacement is because these are relatively standard services that are provided for relatively equivalently healthy patients in a relatively consistent fashion. And then the aftercare is relatively consistent as well. The problem is that outside of a few specific surgical procedures and specialties, the variation that exists in the patient population and in the procedure starts to increase dramatically. And so the only way to provide adjusted services in those spaces are if you have the insight into understanding what happened before the surgery, what happened in the operating room, and what's happening when the patient is convalescing. Because you can't say we can take on risk for these surgeries where the patient's likelihood of having a complication is high, and then pay them with at the same rate as one where a patient who comes in with much lower risk is then going through the same procedure. So that's why you see these models moving into, some of the neurosurgical specialties, spine surgery, orthopedics. Even there's been some work in cardiac. But there's a lot of hesitation to move into some of the other spaces where there's a lot more variability in the outcomes of patients, because what happens is you can be willing to take on risk, but all it takes is one very complicated patient who has poor outcomes for this not to become a well-balanced kind of system.
Thank you for that. I'm very excited about bundled payments, and thank you for underscoring how difficult it is, especially with patients and having, I think that's an opportunity, good visibility on what happens before, after, being able to track it, and to a certain extent, being able to influence that. It's difficult. Now, Dr. Bott is in the cardiac service, which has changed dramatically. And if anyone of you guys are cardiac service innovators or will somehow impact the heart, she's going to talk now about payment changes for telehealth, remote patient monitoring, and as we saw from the illustrious Dr. Yang, hospital at home, and how that the payment model has changed and opened up opportunities for massive innovation, in my opinion. Dr. Bott, I'll
agree. So I'm going to go back for 1 second to Trevor's last answer. I'm going to take you all the way back because it was important. He talked about democratizing data, and I just want to point out that when we're thinking about who our patients are and how we're engaging them, they need to trust us. And when we democratize data, we take a lot of the racial and ethnic groups who do not feel trust in the medical system, and we say, here, this is yours, and now we're here to help you. So I cannot emphasize that enough. It also leads directly into what we're talking about now, which is thinking about what our patients want. If there is a group out there that is going to force our country, our capitalistic society, to allow them to give us the data we need, get the care they want in their home in a way that is convenient and cost effective. It is actually the patients that are going to drive this. And I think that's great because they're not the only consumers, right? We are consumers, you are consumers. But I think that's important. I would say you should really watch the value-based care groups. So I would watch the Kaisers. I would watch UPMC, who's taking on its own risk. I would watch the Iora Health and the multiple other self-contained, really primary care groups. I would watch the population health field when we talk about hypertension. Then when you look at what Dr. Bratt was just talking about, I'm terrified, right? You want me to take the risk on for all of these hypertensive patients. They are so different, not just medically, but in terms of social determinants of health, that it is very hard for one person alone to picture how you're going to take that responsibility on. But that's what these organizations are doing, and they're leading the way for us. For the rest of us, we're fee for service. And so now we're looking at COVID where we had waivers and said, you can do telemedicine. We're going to treat it as if it's an in-person visit. And there's payment parity. And unfortunately, that is in fact shifting in a direction that is less favorable for us. So what we are trying to do now, those of us who work in this field from the academic side, is how do I create a bundle? How do I create a maternal health texting algorithm about blood pressure management to decrease the rates of maternal mortality in this country? Because no one wants to come in when they have a new baby to get their blood pressure checked in the office. But multiple studies show that if I text you and remind you to take your blood pressure, I can manage you via text. So how do I take these kind of things and show value? And how do I create the equivalent of a population health bundle and then sell that to you? So we're still in the fee-for-service model in this. But now we're just trying to say, okay, can we digital health bundle because the system understands that? So maybe we can play a little bit to the system and still get what we're doing in. So I think that's where we're headed. But we have to head there fast because otherwise waivers are ending and payment parity won't necessarily be a thing. And the people who will suffer are those who actually need to connect by telephone because they have 3 jobs and they can't afford to take half a day to drive into Boston to see their doctor for something that didn't need an exam.
Thank you, Dr. Bott. And as we move to Mr. Perry and talking about who pays for things, and I know that we're here at a classic med device, and what you guys do well is good data, 510K cleared, FDA approved, surgical suite, in-hospital suite. But what we're seeing is this connectivity. how do we take that level of what you guys do? How do we move it into the home? And once we start moving it into the home with Hospital at Home, how are we beaming that data back and forth? But with that said, there's so much information, and I think COVID has highlighted public health, wellness, taking care of yourself, that Mr. Perry, you're going to highlight for us that there's lots of opportunities to give real innovation, real value direct to the patient.
Yes, thank you. So I think this is a great conversation because I've sat in your seat before thinking about, all right, I've got this idea. How do I get it paid for? And who pays for it? And when we think about COVID, there was one big thing that happened there from a payer perspective. And I've worked with third-party payers for my entire career. We took what was considered standard of care, which is something that we'll pay for. We're thinking about usage, cost, and efficacy. Those are the three things that we care about the most as a payer. So therefore, that's what we're going to cover, and we're going to consistently cover that. So it's either you want to play in that space or you want to play in the innovative space. And the innovative space it's the fun place to play in, and it's where a lot of the ideas come from. But a lot of times, it doesn't get covered. Well, COVID actually provided an environment where innovation started to get covered. We started to see companies thinking outside of the box around cost, around efficacy, and most importantly about demand. Because when you think about telehealth and telemedicine came because it was a demand all of a sudden. We needed to do that. So what did these companies say? They said, all right, we're going to start paying for that. And so moving forward, when we're thinking about the balance, and now that we're starting to get what we would call as the new normal, what is the standard of care and what is innovation? I think that we always need to be pushing the envelope at innovation. But if you're thinking about how you're going to get things covered, you always got to think about those three things. It's about costs, it's about efficacy, and it's about utility. And it's not all three of them, but you got to at least have two of those three. So it's important to think about that as we're moving forward and as we're developing new things and new thoughts.
I would just underscore that. And I work for a payer provider. I work for the VA system. So I work in the ER, the urgent care, and I work in so many systems within the VA. But what happened in terms of telehealth, within 24 to 48 hours of the emergency announcement in Massachusetts, we flipped 95% of our primary care to telehealth. We just made that flip overnight. And understanding how much innovation actually rolled out in the emergency room setting, we have follow-up telehealth visits. We have, I can telehealth with a patient in my actual ER, so I can give them an iPad and I can stand outside the room just so that I don't have to go in there many extra times. And then there's been some really interesting ER telehealth innovation where some of the patients waiting in the ER waiting room will be seen by a telehealth ER physician before they actually get to me. Innovation has really been accelerated because of COVID. And as we're wrapping up this panel, because I don't remember what time we're wrapping it up. I am sorry, it's been a hectic day, but I suspect it's soon. I'd love to hear from, and I'd also want questions from you guys. So I'm gonna leave time for questions for you. I'd love to hear from each of the panelists. What do you see as the most exciting thing you would want from medical innovation, medical device in the next 6 to 12 months? Where do you think the opportunity is ripe? And that for whatever it is, what would be the perfect solution, or what would be the ideal solution? Outside of being inexpensive, interoperable, and 99% sensitive, and 99% specific. Is that a big question?
Sure, I'll start it off. Well, I think that really, kind of the common theme here is about how to use big data and how to use innovation. I think that the companies that are going to really thrive are those companies that are focused around compatibility. How do I take as much as possible and create predictive modeling, creates the ability for physicians to not have to do as much of the on-the-spot decision making. There's the way for us as an industry to provide more insights by giving better data, not just lots of it.
Yeah, I actually think that it's very consistent with what you're saying as well. Is the as we move forward, the ability to have systems that communicate appropriately, whether it be in the operating room or outside the operating room, where the data that exists is easily accessible in a high quality format by anyone is certainly the most exciting aspect of what is possible, I think, in the near future. There's a big push to open up the EHR through FHIR applications, and that is very exciting, but that only goes so far, and that only covers the existing characteristics of the data that is in the EHR. And so as these new sources of information start to arise, having a well thought out plan as to how to make that data accessible is in itself is an innovation. It's something that hasn't existed historically. There's been just a push to move data and get data out as quickly as possible. And I think thinking about kind of the long-term usability of these different data sources and how they can be integrated is in itself an innovation that has tremendous opportunity over the next, 2, 3, 5 years that I am seeing and that we're all seeing in the healthcare space.
Very important. And Dr. Bott, as we end with your closing remarks, I don't know what you're going to say, but I would love for you to tell the story about technology actually allowing you to become closer to your patients.
Sure. All right, I'll lead with the story. I had a patient who I just met them. He had congenital heart disease. That's what I care for, kids who are born with disease. And when I first met him, he had perhaps the worst murmur I'd heard, and I knew he needed another surgery. This would have been his third open heart surgery. He was 32 years old. And I wanted to get the testing to confirm I was right and to really be able to tell him what we were going to do and then bring him back in and sit and hold his hand. Norman Rockwell, I have those paintings in my office, like hold your hand, be that doctor. And this was pre-COVID. And he said, Doc, remember you said you do this telemedicine thing. Why don't we just do it over video? And I thought, no, you have to come in. I have to hold your hand. I'd be a horrible doctor to do this over video. And I pushed, and he pushed even harder. And so we did it over video. And afterwards he said, thank you. I would never have been able to do a third surgery if I weren't at home with my family, with my kids, reminding myself why it is that I'm going to go through this yet again. And so I needed that from you. And that was 6 years ago, long before everybody else started doing telemedicine. And it was really one of those important days where I was thinking telemedicine was making me less of a connected doctor. And in fact, since then, when I listen now, my patients love telemedicine. They notice the smell of the clinic. It bothers them. They feel not right sitting in a blue gown and being left there in the cold. I mean, there are so many things that they just, of the experience that is not humane in what we do. So maybe let me turn that to my last comment, which is we are clunky. We are not really patient-centric, and we're very episodic and reactive in our current mechanism of healthcare. Don't get me wrong, we do great work. So if you could come to me with ideas, concepts, devices that could, number one, create some form of continuous care of my patient, but once you do that, then make it efficient and in fact improve upon the inefficiencies that we have, which are many. And then third, if you could ensure that that is a mechanism where a doctor and a patient feel closer. And I'm certain that you can probably think about just yourself as the patient and figure that out. Continuous care, efficient care that brings us closer. You will get a lot of buy-in because we are tired as clinicians. We are facing an epidemic of burnout. And it's only worse now than it was 2 years ago. So if you could do those things, continuous care that is efficient, that brings me closer to my patient, I'm all in.
Thank you for this wonderful panel discussion. And it was just beautiful ending on that note of why we're here, what we're doing, what you're doing, and the patients that you're helping. So with that, I am going to open up the floor to questions. We are friendly people. We would love and adore to interact with you.
Questions, comments? We have a couple of minutes before our next panel begins, but I want to give folks a chance to have something to say or ask a question. I knew I should have stood next to you.
Hi there, Dr. Jim Phillip here. how will we ever get to the point where we can get the shared data that we need, which is question number one. And question number two, how can we convince manufacturers who are doing the data collection in our monitors and then sending it to this horrible, horrible thing, oh, I'm sorry, I shouldn't say that, called Epic, that keeps data at least every 2 minutes or so and loses everything that we really want to have. What will ever get us there? Who do we have to lobby with? Is it our congressman? Is it our president? Is it the other areas of government? What can we do to get us on the track so that we really are a smart country doing smart things with our patient information?
Thank you. I really appreciate that question. And we clearly have a wonderful, brilliant clinician in our audience. And I think you're underscoring the importance of working with data, opening up data, making sure it's not locked into the EHR. I think we heard that from our panelists. And just underscoring the power of data and the critique, concern, and frustration from the physician, clinician community of having more access to that because you're seeing the power of it. So we're in a data transformation era like no other. Do the panelists want to contribute?
I'll say one thing to that. I think the solution is around permission. I do not believe that this is a top-down approach. It's a bottom-up approach. We need to focus on how we're permissioning, make sure that it's very transparent. So as a developer of either a medical device or any kind of a service, you need to make sure that it's very, very apparent on who's using this data and why, because that provides the insights of where that ends, right? Where can I use this data? What is it compatible with? When we think about electronic medical records and how those are utilized, the real question when you ask a patient is, who owns this? What can I do with it? Why? If you answer those questions and if the bottom understands where that sits, the top will have to react to it.
So I completely agree with you. Had you asked this question, let's say 3 years ago, I would have said that you're probably right, that the only way that data access will exist will be from the bottom up. But I think what happened during COVID was so transformative as it relates to the ways in which people have been sharing data over the last 18 months that I think that there is an opportunity now that didn't exist before. So if you look across the world, and I'm part of one of these consortia as well, where people have found ways to rapidly share data, huge amounts of data across EHRs, across healthcare systems, across countries. And they've done it in ways that are either privacy preserving or at least are safe enough where access to that data does not significantly endanger the data asset that this group has. And so I actually think that people learned in the last 18 months how to do this in a safe way that didn't cause tremendous amounts of risk. And so I think the likelihood of this happening again is very, very high. The NIH is now funding these types of efforts very, very aggressively. And so I think you'll see over the next 24 months, an amount of information that will be available that was never available before, simply because groups learned how to work together and do this safely in the last year, and now are willing to do it more often because there weren't these huge breaches where all of a sudden CMS went and had to sue them, because people were able to share data rapidly while being able to hold on to maintain methods that preserved privacy and kept the data safe. So maybe I'm just being optimistic, but I see a huge change in the way people are willing to share data now.
So if we look globally, just quickly, there's a reason that device companies all go to Europe first and then come here, right? So it's the US. So I will say, please do talk to Congress. Interoperability is on the table. all the time. There are so many bills that have interoperability as part of it. And so feel free to reach out to me. I can tell you which ones they are. The House Ways and Means Committee will look at some of these. And if we push people, eventually we've got to change this from a legal standpoint as well.
So I want to say a big thank you. This has been a wonderful panel. I really appreciate you guys coming out. The panelists were amazing, fantastic, brilliant. Thank you for sharing your time with us. Thank you to the audience for sharing your time with us. Can we get a big round of applause?
Thank you all.